Bismillahirrahmanirrahim. So my presentation today will be on artificial intelligence in the management of gynecologic cancers. So a few years ago, I had an interview for an academic position. Basically, with these interviews in the UK, especially, you typically discuss what you have done as research work, stuff like that. And I remember I got excited and I spoke about my experience in machine learning as one of the things that I would say I'm interested in. And one of the professors, actually very prestigious university, asked me a question. And he said, okay, so are you planning to get robots to actually treat patients instead of us as doctors? It was a very intense question, very interesting, but something that you feel like it's more of a stereotyping about machine learning and the relationship between machine learning and robots, which is not exactly true. A couple of years ago, we submitted our first project on machine learning on placenta accreta spectrum. It was a very prestigious journal, and one of the reviewers actually wrote a very interesting comment. He was obvious. He said, I don't know exactly what machine learning is, which is nice. But he said, you know what? I think there's something wrong here because you said this study is a retrospective study. At the same time, you said it's machine learning. But I assume, the reviewer said, that if it's machine learning, it's learning, then it should be a prospective study because the machine needs to learn by experience. That was another interesting comment. So these two brief stories actually are exactly why I'm doing this presentation. Because one thing I recognized that even in Western countries and prestigious universities, machine learning is still not there yet, especially in the field of obstetrics and gynecology. And I always think it's an opportunity to explain things and remove any sort of stereotyping on machine learning. Because if we get to remove this barrier and think about machine learning as just another approach to research, we can always catch up and actually be up to date and contribute significantly to this type of research. I'm talking about Egypt, I'm talking about Egyptian universities basically, because it's a new field, it's not everywhere, and we have the potential to be there and do our research to be in line with international universities. The other thing, and I know most of you and myself are actually clinicians, so it's not necessarily that we are interested in research, but we should also know, because that's the upcoming wave, so how, as clinicians, we could make use of this new technology. So, I would like to explain a few things about machine learning. I promise I'm not going to be sophisticated, I'm not going to use any technical terms, but just the simple words. So the bigger term here is actually artificial intelligence, which simply means that the machine can do something that you didn't tell the machine to do. Basically, that's in simple words. Machine learning is a subset of artificial intelligence, which basically means the machine to learn. And when I say a machine here, it's not robots. That's a stereotyping. Robots do not mean machine learning. Not all robots use machine learning, and machine learning is not necessarily something that's done through robots. But the machine here means the computer, basically. So we would like the computer to learn. And the way we do that is it just simply reproducing the process of us as human being learning. So for example, like a child has a dad. The child, for the first time, is seeing a dog. He doesn't know what is that exactly. So the father is saying that's a dog. Next time, he's seeing a different type of dog. So he still thinks a different creature. And the father says, okay, no, that's another dog. One time, by one time, by one time, the child will be able to know, even if he sees a different type of dog, has never been told that this is a dog, he can tell this is a dog. Because basically, he can start to recognize what are the similarities, the voice, the way the face looks like, and then can make a conclusion, even if it was not taught that this is a dog. That's exactly what we're trying to do with a machine. So that's exactly how machine learning is different from traditional programming. And when I say traditional programming, it's exactly when you go to the Word, Microsoft Word, and then change the size of the font from 12 to 14. What the computer will do is just changing the size of the font, because the machine, the computer, was told, when I change it, just make the font bigger. He didn't do anything creative here. And this is actually classic programming. Artificial intelligence is different. This is a photo, somebody we all know. And the machine, once he sees few pictures of the same guy, you can show the machine, the computer, a different picture, like a brand new picture of the same guy, and the machine is able to say, yeah, but it's the same guy. Even if the machine didn't see this image before, just because it was taught by seeing multiple images that this is how this person should look like. And this is a wonderful thing about machine learning, if we think about it, because basically it bridges a gap that we have always been complaining about. Evidence-based medicine against experience. Because we think evidence-based medicine is important, like getting our practice from numbers and from proven data that this is what we should do. But we also appreciate experience. We think that we see things, we have conclusions ourselves as human, and we feel like that's still not necessarily fully appreciated in evidence-based medicine. What machine learning does, it takes both of them. It makes experience, learning, something that can be made in figures and equations. So it's still an evidence-based medicine. Okay, I'm not going to go through all the whole story about machine learning, but I'm going to say is basically it's an old story, starting at 1950s. That was the first time machine learning was done, and actually it was made to actually recognize images, which is very interesting. And there was a lot of nice trials, but at a point they stopped trying to do any further act on machine learning because they were not sure if that's financially reasonable. They were thinking they are spending a lot of money, but they are not getting anything that can make them gain money. But eventually, at the 90s, of course, when internet has been available, personal computers have been available, they found so many things that can be done with machine learning on commercial level. But in 1997, this is the first time that medicine recognized machine learning, and we should thank radiology for that. They start using machine learning to read images, which has been a long time ago. But that doesn't apply to obstetrics and gynecology, who actually recognize machine learning relatively recently, maybe over the last 4 or 5 years, when it starts to be really a thing in obstetrics and gynecology. Okay, I'm not going to go through the types. As I promised, no technical terms or anything. But I would refer to the uses of machine learning. So basically, we have two major types, traditional one and deep learning. I'm highlighting that because traditional machine learning is exactly what we do in statistics. We give the machine, the computer, data in tabulated form, having variables and outcome, exactly with traditional statistics. So it's not a different thing necessarily. Deep learning is another type of machine learning which actually deals more with media, so voices, recognizing voices, images, things like that. But both of them are applications to machine learning. So even when you're trying to set a prediction model, for example, to predict clinical outcomes of a disease, you can use that through traditional machine learning as an alternative to traditional statistics, basically. Again, that is a little bit technical, but I just want to make it as simple as I can. Just to give you an idea how machine learning works. Because, as I mentioned earlier, my reviewer, my friend, the reviewer, who mentioned that how a retrospective study could cause the machine to learn. But simply, as I mentioned, we give them a table, a lot of patients in a table form with a lot of variables. We don't intervene, we just don't select any variables. We give the computer all the variables we have and give them the outcome. For example, response to a new drug. A patient responds, a patient didn't respond. That's the outcome, yes, no. And then the computer is trying to make the best guess, taken patient by patient, starting with the first patient. He doesn't have any idea how these variables can predict the outcome. So he makes up just a random equation, just weighing every single variable and how this variable could affect the outcome, trying to make more of an equation. And then the equation is probably wrong because it just made up just a guess, but the computer can recognize how far wrong it is, and it starts to change the equation, and if it finds that the error is getting less and less, it goes in this direction, till it gets the perfect equation that can recognize all the variables and give the best prediction. And that's how we develop a prediction model. But to develop a prediction model, you have to do these other two steps. The first thing is validation. So you tested or you created the model, but you need to get brand new data, raw data, that the computer hasn't seen before. And then apply your prediction model on this new data to be sure that the computer still can predict the outcome correctly. And it was not just that it memorized the data that it has, and it can only work on the data it has. I want to be sure that it can work on a new data and can be done and generalized to the general population. And then the last thing, you have to develop a software application, because these equations are very complex, not like a Bishop score with everything getting numbers or so. It's a very complex equation that the clinician cannot use. So we use a software where you can put the inputs, and then you get the probability or the results in an easy way. And this is how clinicians can make use of these types of research. So just try to run fast on these topics, but basically, this is how we can use machine learning in research and clinical practice. So three major things. As I mentioned, predicting outcomes, like making a prediction model to predict a complication or a response to treatment, for example, classic one. The other one is actually exactly like radiology, reading images, because we are overlapping with radiology doing our own ultrasound scans. So you can have machine learning softwares that can read images, including ultrasound, CT, MRI, and so on. Last thing is reading other investigations, and we'll go through that. So I wouldn't go through all these, but these are examples of machine learning in obstetrics and gynecology. As you're probably going to see, most of them are in the last couple of years or so, because all of a sudden we're having this kind of curve in researchers' interest in machine learning. So these are some sort of examples of how we use machine learning, like a model to predict obstetric sphincter injury, using second stage variables to predict neonatal outcomes, prediction model for readmission of patients with hypertension during the postpartum period, prediction models for intrahepatic cholestasis, for preterm labor, predicting actual weight of the baby, and prediction models for postpartum hemorrhage, for VBAC, for neonatal outcomes. And actually the last one is one I was involved in at Mayo Clinic, which actually uses a whole complete model that is an alternative to the partogram, which everything in labor is included for an individualized prediction of clinical outcomes. So a lot of things, I'm not going to go through all of them, but I would like to speak about our own experience. So of course, in MCOG, the AI unit was established in 2021, and it was basically made to support machine learning project in collaboration with multi-center study office, because most of these projects really need large data, so we have to collaborate with prestigious centers all over the world to get enough data for machine to learn. And we have been working with Silver Axon, which is the software collaboration that uses the final model and make it as a software for clinicians. So through the years, we have been working with a lot of centers in Europe, in Asia, and Africa. And we have already been able to publish few projects for now. So the first one was PAR A and PAR B scores, which were basically machine learning-based prediction models for clinical outcomes of placenta accreta spectrum. And recently, just last year, we were able to publish new results from a European-based network about prediction models in gynecologic cancers. So that is our ECISS project that was published last year, and it basically stands for Endometrial Cancer Individualized Scoring System. So I'm actually not going to go through all the details because my colleague who's very brilliant, who's going to go through them, Dr. Muhammad Esmat, in the next presentation, but I just want to cover a few things. So basically, this ECISS. The project was basically intended to find an alternative to the classic vago staging, which just classify patients stage 1A, 1B, based just on the size of the disease and the number of lymph nodes. We were trying to make something that's more individualized. So it's based on everything related to the patient, starting with the age, race, body mass index, grade of the disease, histopathology of the disease, everything that could be found as a baseline. And actually, we made 3 models. We were a little bit ambitious here, so we tried to make it more intense. So the first model is exactly the basic one that's an alternative to the vago staging, which actually what it does, it takes every single information from the baseline, including demographics, disease characteristics, and preoperative imaging. And it's exactly the alternative to the vago staging. It's trying to tell the patient what is the expected prognosis once the patient is diagnosed with endometrial cancer. The other thing is model 2, which I think the most interesting, is we used the score from model 1 and then added all the information needed from the time of treatment. So surgical details, basically, what surgery was done, what type of surgery, what was done exactly, lymph nodes, omentectomy, things like that. And we added details of radiotherapy and chemotherapy. And the reason for that is we are trying to give the clinician the opportunity to actually test the plan he is intending to do to treat this patient and see how the prognosis would be if this plan is made. And then can come up with changes in this plan to see what would produce the best outcome for this patient. So before doing anything, actually, just to plan for treatment. And using this, you can actually make an individualized plan for each patient, not just for general staging, but for this particular patient, what she needs. If she needs radiotherapy, external PM, brachytherapy, chemotherapy, needs omentectomy or not, lymphadenectomy or not, these sort of details. And the last model was model 3, which actually used the score from model 2, and then adds all the events that happen at the time of surgery and immediately after. For example, if you were able to remove the whole tumor or not, and if any complication just happened at the time of surgery. And the reason for that is you can give the patient the final prognosis after all the treatment is done. So, again, I mean, I'm not going to go through the details, but you can guess. This is the AUC. This is the orange line is actually how the vago is predicting clinical outcomes, including survival and recurrence. And the other lines are actually the 3 models that I have mentioned. So you can see absolutely there is a significant difference in performance. So as I mentioned, the application for that is, first thing, you can tell the patient about her personalized, precise prognosis rather than just using the general staging prognosis, saying that stage 1 has a prognosis of survival of whatever 95 to 99% or something like that. You tell her probability as an individual based on her own disease, her own condition. But at the same time, you have the opportunity to specify what treatment plan would serve the best outcomes for this particular patient. And as I mentioned, you can always tell her the prognosis at the beginning of diagnosis and the updated prognosis once the treatment has been completed, which is not typically something that we necessarily do with vago staging. And through this, the ECISS calculator was created, version 1, that was in May 2022, which is a software that can make these calculations for you so you don't have to worry about the complex equation. So these are the future directives we're planning to do. So first thing, ECISS version 2 is undergoing now, and it's actually based on 11 European centers, and it uses genetic and immunohistochemistry information in addition to the other information I mentioned. So hopefully that would be a breakthrough. OCISS is undergoing with 12 European centers, so it's basically the same thing, but on ovarian cancer, and similarly, VCISS is on vulvar cancer. So hopefully we can get a set of prediction models for that. These are my reference. Thank you so much for listening. Thank you. I would leave it for my brilliant colleague, Mohammed, who is absolutely an amazing friend and colleague, who will take over and speak a little bit in more details about the ECS-ISS project and how it was created and everything. But thank you so much for giving me the time to give this presentation. Thank you.